Hi everyone, I'm Jess, and in this talk we're going to be discussing the difference between fresh and frozen-thaw embryo transfers and how they affect endometrial receptivity. So firstly, infertility is defined for women under 35 as a failure to achieve a clinical pregnancy after 12 or more months of regular unprotected sexual intercourse, and unfortunately in Australia infertility affects 1 in 6 couples. This diagram represents the process of IVF, which has revolutionised the treatment of infertility. The process starts with ovarian stimulation, egg retrieval, and fertilisation. After growth in culture, there are 2 pathways an embryo can take. It can be transferred fresh into the lining of the endometrium or undergo sited preservation, where it is thawed prior to implantation. While there is an increasing trend to use frozen-thawed embryo transfers due to their high success rates, West Australian data from 2016-17 showed that almost 60% of embryo transfers were in fact fresh. In an aim to answer some of the questions surrounding this topic, Shapiro and his colleagues conducted this study in 2011. Their research objective was to compare success rates between fresh and frozen embryo transfers in an aim to analyse endometrial receptivity. Shapiro hypothesised that the controlled ovarian stimulation required for egg retrieval impairs endometrial receptivity and thus causes a decrease in implantation and pregnancy rates. The study was a prospective randomised controlled trial of 103 patients undergoing their first cycle of IVF. Patients underwent ovarian stimulation, blastocyst retrieval, and then were split into fresh embryo transfer or frozen embryo transfer groups. Following implantation, they measured the clinical pregnancy rates. Importantly, there were no significant differences in confounding factors between the 2 groups. This included age, diagnosis, and BMI. There were, however, differences in the outcomes of the clinical pregnancies. The frozen-thawed embryo transfer groups had significantly higher levels of implantation, clinical pregnancies per transfer, and ongoing pregnancy rates. The study concluded that the differences in these results was due to the superior endometrial receptivity of the frozen-thawed embryo transfer groups. However, there were limitations to this study as direct endometrial receptivity could not be observed and only inferred. Therefore, future studies need to be completed to confirm these findings and analyse the physiological processes occurring. These results, however, have the potential to change IVF protocols in Australia, and considering in WA today there are still more fresh embryo transfers than frozen, this study is highly significant. These are my references used in this talk. Thank you for listening.